Hi, I'm Andrew Miller. I'm here to talk about papers published in the past year in respiratory care on pediatric mechanical ventilation. About me, I'm a section editor for respiratory care. I'm also a pediatric RT and ECMO specialist at Duke University Medical Center, and I have no conflict of interest to report. So, in papers published this year, we had 9 total pediatric mechanical ventilation papers, 7 original research, and 2 review articles, 1 systematic review, and 1 narrative review. And these are on a wide variety of topics, which you'll see coming up. Before we talk about our first paper, I just want to review real quickly the physiologic dead space, which is what our first paper is about. And physiologic dead space, or VD to VT, it's been shown to be associated with mortality and ARDS in both adults and children. Unfortunately, in clinical practice, it actually requires volumetric capnography, which is not widely available or widely used. And here's the equation for calculating the physiologic dead space. So you have PaCO2 minus the PeCO2, which here is the mean expired CO2. So this is not the end tidal CO2, which is why you need volumetric capnography, divided by PaCO2. So this has led various investigators to try to figure out if there's an alternative method to determine physiologic dead space. And so one method that has been investigated is the end tidal CO2 to dead space, or to alveolar dead space fraction, which is AVDSF. And again, this is a similar equation, except instead of the mean expired CO2, you have the end tidal CO2 here in the equation. And another surrogate marker that is highly related to physiologic dead space is the ventilatory ratio, and that's described here. So it's the measured minute ventilation times the PaCO2 divided by the predicted minute ventilation and the ideal PCO2. And what they use when they talk about ideal and predicted minute ventilation, so the ideal PaCO2 in this model is 37.5 millimeters of mercury, and then the predicted minute ventilation is 100 mLs per minute per kilo, but obviously this can vary quite a bit in clinical practice. And our first paper is from Bahala and colleagues from the UCLA Children's, and they looked at the ventilatory ratio to see if it was associated with outcomes in children. So they enrolled 180 subjects who were less than 21 years of age, with an OI greater than 4 or an OSI greater than 5. And then they evaluated the relationship between the ventilatory ratio, AVDSF, mortality, and time to extubation. And what they found is that there was no relationship between ventilatory ratio and mortality, but there was a relationship between the end tidal CO2 dead space relationship, and that was associated both with mortality and rate of extubation. And then our second paper is on dynamic airway driving pressure and outcomes in children with acute respiratory failure. This is by Ralph et al. And what we know in adults is that driving pressure is associated with mortality in adult ARDS, and this is likely due to its quality as a surrogate marker for transpulmonary pressure. But PEDS data, like for most things, are quite limited. So this was a retrospective study of 161 children with a PF ratio of less than 300, and they had to use PIP as a surrogate of plateau pressure because most centers, including theirs, don't routinely measure plateau pressure in children. And what they did is they actually created 2 groups based on what they call the dynamic driving pressure, which was the set delta pressure, and greater than or less than 15. And so what they found was a dynamic driving pressure was associated with worse outcomes, but no difference in mortality. But it's also important to note that this study was fairly small, so it's unclear if there really is a relationship, and we just need more subjects to actually determine if this dynamic driving pressure is associated with mortality. But they did find worse outcomes, so increased duration of ventilation, decreased ventilator-free days, longer ICU length of stay, and a longer hospital length of stay. And then ventilator alarms are a big problem in the ICU. It definitely contributes to alarm fatigue. So this is an editor's choice paper from the spring from Leo Longa at UCLA Children's. And this was, the prevalence, proportionality, and cause of ventilator alarms in a PICU. And what they found is, not in their study, but in prior studies have shown 73% of ventilator alarms are non-actionable. So they looked at all of their ventilator alarms in 2 different ICUs using 2 different ventilators. And what they found is that there was 22.5 ventilator alarms per day, per patient per day. And the most common alarm was high respiratory rate, inspiratory flow over range, high airway pressure, low PEEP, and apnea. And then here's a very nice graph kind of illustrating what the most common alarms were in terms of distribution. So you can see almost 38% here are inspiratory flow over range, and then high airway frequency, so high respiratory rate. And so another challenge in clinical practice is how to set PEEP and how to measure response to PEEP. So Elia and colleagues did a study titled Longitudinal PEEP Responses Differ Between Children with ARDS and at Risk of ARDS. And so it's important to remember that our end expiratory lung volume is the functional residual capacity plus whatever lung volume is increased related to applied PEEP. And this can result in alveolar recruitment, which is good, but it can also have deleterious effects with overdistension. So they enroll 32 subjects with or at risk of ARDS, and what they found is that what you would expect is that the ARDS subjects had lower compliance, higher stress and strain, and these were affected by changes to PEEP. But even though the stress and strain were higher at a PEEP of 10, they were still well within what we would think are safe limits. And then the correlation between end expiratory lung volume and compliance was 0.6. So there's a relationship there, but it's not a super strong relationship between end expiratory lung volume and overall lung compliance. Yeah. Our next paper is Extubation Readiness Practice and Barriers to Extubation in Pediatric Subjects from Johnny K. from the University of Indiana. And what we know is extubation failure is common in the PICU setting. We do ERTs to determine if they're ready to come off the ventilator. And this group hypothesized that there was a variation in the methods used to evaluate extubation readiness in their center. And they also wanted to identify any barriers to extubation in patients that had passed an ERT. And what they found is that ERTs were done before 69% of extubations, 39% of those patients passed their first ERT, and then 30% passed the next ERT. And then the main reasons for extubation delay was procedures, neurologic status, and no cuff leak. And then the failure rate was 5%, and what they found is that a respiratory etiology, so if you were on the ventilator for respiratory failure, you were 9 times more likely to need reintubation. And what they didn't find that daily SPTs had any impact on the risk of extubation failure in this observational study. And our first systematic review is epidemiology and outcomes of ARDS after pediatric trauma. And what we know is that trauma is a frequent cause of ARDS. And in this systematic review of 9 studies, they found that the incidence of ARDS after trauma was 1.7 to 6.7%. And they identified quite a few risk factors for developing ARDS, including race, mechanism of injury, injury severity score, tachypnea baseline, GCS or mental status, chest injury, so blunt trauma versus penetrating trauma, etc. And they found the mortality range was quite a bit. It ranged from 7.7 to 34%. And then importantly, what they found was death from refractory hypoxemia was quite rare, with the most common cause of death being neurologic failure or multi-organ system failure. And we're going to end with 3 papers on high-frequency jet ventilation from our group. And as we know, infants with severe respiratory failure may require high-frequency ventilation for a variety of reasons. High-frequency jet ventilation has been used quite a bit in the NICU setting, but there are some centers that use it in the PICU, but it's not widely used, and there wasn't very much published. So we did a retrospective review. We were able to enroll 35 subjects. Their median weight of 5.2 kilos, 2.9 months old, mostly intubated for respiratory failure. And jet ventilation was started pretty quickly after intubation, about 0.6 days, and then the kids spent a median of 5.4 days on high-frequency jet ventilation. And then the overall outcomes we found: 74% survived, 26% needed ECMO, 42% had to be transferred to other high-frequency modes or ECMO. And then the major finding for this is in the short term, what we found was that CO2 clearance significantly improved, but there was no effect on oxygenation, and pH increased from 7.18 to 7.39. And then PaCO2 decreased from 64 to 51, but again, no change in oxygenation. And our second paper on high-frequency jet ventilation was in infants with congenital heart disease. So similar to other patient populations, kids with congenital heart disease may also need high-frequency rescue ventilation, and these patients are characterized by very complicated cardiopulmonary reactions. And similar to our other study, this again quite small, 27 subjects, but the median weight was 4.4 kilos. They were 2.5 months old. Most of them had cyanotic heart disease. And then jet ventilation was started much later in contrast to our study in the PICU, so 8.4 days in this study versus 0.6 days in the PICU. And then the patients didn't spend as long on high frequency jet ventilation, so they only spent 1.2 days on high frequency jet ventilation, which may be a characteristic of the patient population where they improved rapidly. And then 48% survived and 26% required ECMO. And then similar to our other study, we found that CO2 clearance significantly improved, but there was no measurable effect on oxygenation. And finally, our last paper is we did a narrative review of high frequency jet ventilation, and we covered how jet ventilation works, and we went over all of the evidence for high frequency jet ventilation in neonates and children, and then we made some basic recommendations for daily clinical practice. And thank you. Please follow us on Twitter at Respiratory Care, subscribe to our YouTube channel, and you can also check us out on Facebook. Thank you for listening.